I would like to thank the organizers of this conference, and particularly Harris and Roger, for giving me the opportunity to speak on this controversial topic. These are my disclosures. In this presentation, I'm going to be discussing medically supervised weight loss programs and why I think we should not be referring to our obese patients to. This graph shows the typical yo-yo weight curve in an obese person. Weight loss programs always result in short-term weight loss, and that weight loss is invariably followed by long-term weight regain. The diabetes prevention program is one of the most highly cited and influential medical papers that has ever been published. It was a randomized controlled trial that was designed to see if a meticulously designed medically supervised weight loss program could enable long-term weight loss and thereby prevent patients from becoming diabetic. It was published in the New England Journal of Medicine on February the 7th, 2002. And it has been cited more than 13,000 times, which is almost twice that of all these other obesity papers combined. And it forms the basis for the obesity guidelines published by each of these national and international organizations. There were two goals to this study. Goal number one is to prove that their weight loss program could enable long-term weight loss, and thereby achieve goal number two, which was to see if this would prevent patients from becoming diabetic. Many short-term trials have shown that weight loss can be achieved. The specific goal of the DPP was for patients to lose 7% of their weight over 6 months and to maintain that weight loss over 4 years. First, patients were placed on a 1,500 calorie per day low-fat diet. This is a 1,500 calorie diet. This does not include breakfast, or lunch, or snacks, or alcohol, or other beverages. Yet patients were still expected to consume a total of 1,500 calories per day on a long-term basis. Now, how many people in this room are planning on attending the banquet tonight? Show of hands. Keep your hands up. I assume that none of you have had any breakfast, or lunch, or snacks, and that you won't have any alcohol with your meal. Then patients are given a core curriculum consisting of 16 highly structured lessons over a 24-hour period taught by specially trained dietitians, psychologists, exercise physiologists, and doctors. And patients were also offered a toolbox which included free exercise equipment, free cooking classes, extra sessions with a nutritionist, and even free membership in a health club. This was a truly intensive weight loss program. None of you, in any of your programs, has a weight loss program that could be as involved as this one is. And these were the results. When the Safety Monitoring Board got together at 2.8 years, this was the data set that they counted. At 1 year, patients decided the lifestyle group lost an average of 7 kilograms. However, by 2.5 years, that weight loss was down to 4 kilograms. I would think that any reasonable person looking at this graph would have speculated that the weight loss was not going to be sustained. Yet when the Safety Monitoring Board got together at 2.5 years, they decided to terminate the trial. They believed that the benefits of this program had been so overwhelmingly positive that it would have been unethical to deprive the control groups from this program. Currently, weight loss programs based on the DPP are promoted by just about every academic medical center in the United States, Canada, and the UK. So why did they halt this trial at 2.8 years? The stated reason for stopping this trial early was that the DPP had reduced the incidence of diabetes by 58%. This is a gross distortion of the truth. The current definition of diabetes is having a fasting blood sugar greater than or equal to 7 millimoles per liter. But clearly diabetes is a spectrum disorder. It simply cannot be defined with a single cutoff point. Patients with a fasting blood sugar of 12 are going to develop all kinds of diabetic complications, while patients with fasting blood sugar of 5 simply aren't. If I had a weight loss program that could prevent a person's fasting blood sugar from increasing from 6.9 to 7.1, this would represent only a tiny improvement. But by definition, it would be enough to prevent him from becoming diabetic. If, on the other hand, I had a weight loss program that could prevent a woman's fasting blood sugar from rising from 7.1 to 12, this obviously would greatly help in preventing diabetic complications, but it would not prevent her from becoming diabetic. She was diabetic before she entered the trial, and she's still diabetic now. To be accepted into the DPP, patients have to be diagnosed with prediabetes, defined as having a fasting blood sugar between 5.3 and 6.9. And these were the results. At 2.5 years, 11% of the control patients had crossed the threshold of 7 to become diabetic, while only 4.8% of the lifestyle group. That works out to a 58% reduction in diabetes. When visualized as a spectrum disorder, one can see exactly how tiny this improvement actually was. So there are two ways in which you could describe these results. The DPP caused a 58% reduction in the incidence of diabetes, or the DPP prevented 58% of patients from crossing the threshold of 7 to become diabetic. At 10 years, the weight difference between the two groups had gone down to 0.5 kilograms, and a recent 21-year follow-up analysis showed that there had been no cardiometabolic benefits for the treatment group. Clearly, these patients had not benefited in any important way from 2.8 years of intensive lifestyle counseling. The look-ahead trial was an even larger, more comprehensive trial than the DPP. In it, they examined each and every one of the protocols that they had used in the DPP, and they refined and perfected them. In the first year, patients had 46 visits with a health professional, as compared with only 25 in the DPP. Patients were also instructed to replace 2 of the 3 daily meals with packaged formula shakes, but they were still expected to limit their total caloric intake to 1,500 calories per day. They were also offered the toolbox, which this time also included the weight loss drug Xanax. And these were the results. At 1 year, the weight difference between the two groups was 7.9%, but by 4 years, it was down to 3.6%. And at 10 years, it was 2.5%. At this point, the safety monitoring board decided to halt the trial prematurely because it had become clear that there were not going to be any cardiovascular benefits for the treatment. So how do medically supervised weight loss programs stack up against the incretin-based weight loss medications? In this trial, patients were entered into a weight loss program. They were also given semaglutide. At 20 weeks, half the patients were switched from semaglutide to placebo. As soon as they stopped taking the semaglutide, the weight loss program patients promptly regained their weight. This is a similar trial using tirzepatide, and this was a trial using the Optifast program. Weight loss programs cause short-term weight loss that is invariably followed by long-term weight regain. 6 months after entering the medically supervised weight loss program, patients are euphoric. They're telling all their friends and relatives how great their new weight loss program is. Then comes the inevitable period of weight regain when patients are forced to confront those same friends and relatives with the obvious fact they have regained all of their lost weight. Then they find another weight loss program. I think that the psychological harm from these repeated cycles of weight loss followed by weight regain is profound, and I have never seen this studied. This paper was recently published in The Lancet. It is a meta-analysis of prospective studies that compare the long-term outcomes of bariatric surgical patients with carefully matched medically treated patients. It included over 170,000 participants. Their conclusion was that bariatric surgery had extended the average lifespan of diabetic patients by 9.3 years and non-diabetic patients by 5.9 years. While neither the DPP nor the look-ahead trial demonstrated any long-term mortality benefits at all. These are the 2024 guidelines and recently published by the American Diabetes Association. They continue to recommend that obese patients should be referred to medically supervised weight loss programs, and they claim that this is supported by a grade A level of evidence. I disagree, and I would argue that these should be the revised American Diabetes Association guidelines. If you are interested, I posted a more detailed discussion on this subject on this 27-minute YouTube video. Thanks for listening.
Thank you. Thanks so much for for that rather provocative talk. Any questions? Any questions from the audience? So I have one. I think it's absolutely fascinating the way in which medical lifestyle intervention has really been the bedrock of our weight management armamentarium. And along comes bariatric surgery, and now along comes medications. Personally, I'm waiting for the day in which a study actually looks at GLP-1 therapies versus absolutely nothing, rather than GLP-1 plus lifestyle versus lifestyle. Do you think that day will ever come to pass?
Just a comment on that. I think the diet and exercise are crucial. I bicycle several thousand miles every year. I'm 79 years old, and I've been doing this all my life. Diet and exercise are very, very helpful. Sending a person to a highly profitable, privately run, medically supervised weight loss program does not achieve that purpose. And what it does, in fact, achieve, it winds up having people delay their bariatric surgery for years and sometimes indefinitely.
I think perhaps I'm finding myself more radical even than you, Dr. Evans, because I would draw the parallel with cholesterol treatment. In that these days, someone has high cholesterol. Do we say, go see the dietitian, you must change your diet? We may pay lip service to that, but they don't see a dietitian, they go on to a statin. To what extent in the future will we be doing the same with weight?
In my opinion, primary care physicians should be using these. Right now, the standard of care, if you go to any medical school, we're being told that we should be referring our patients to obesity specialists. Obesity specialists have a definite conflict of interest because they are running those programs. I think the primary care physicians should, and I am a primary care physician, I'm not a surgeon. Primary care physicians should be prescribing these drugs. Nurse practitioners should be prescribing these drugs. And we should be referring people directly for bariatric surgeries. I think the weight loss programs are more accurate.
There was an article that came out, I forget which journal it was, but it was looking at the amount of time required by primary care providers to do what is expected of them. And that's including emergency care, chronic care, and acute care. And in order to do it, the documentation is required now. It will take you 27 hours a day. It's just there's not enough of you.
Thank you. Question over here.
That's, thank you for that presentation. It seems like a day for these kinds of presentations. But, you know, one of the things that I really think has gone under the radar is the effect of this recurrent aging. Kevin Hall from NIH had detailed quite nicely the effect of those recurrent steps of weight gain, and why it is that patients always migrate upwards in their weight over time with these recurrent efforts. And I think that what he showed, if I'm not mistaken, is that there was a decrease in the metabolic rate every time you treat people in this way. And because of that, when they regain more. I think, you know, it's true that our primary care colleagues are underwired with all the responsibilities they have. And this is why I begin to think that there's some drugs that are safe enough not to have to be prescribed. Maybe people should be able to just buy it.
I think that's the perfect note on which to end this session. Thank you so much for your enthusiasm and engagement.